And next in our Shark Tank episodes, we have Dr. Jack Rychik from Children's Hospital of Philadelphia, and he is going to talk about a reliable, accurate tool to characterize and grade individuals with Fontan circulation.
Thank you very much. Thanks to Jody Smith for the invitation to present to you at this Shark Tank competition. I want to thank the organizers of the Mended Little Hearts meeting this year for the opportunity to present my idea to you, which I'm going to try and sell over the next 10 minutes. That is the value in development of a reliable, accurate tool to characterize and grade individuals with a Fontan circulation. Our objective today in the care of the lifespan of the patient with a single ventricle is to get from fetal point diagnostics to having a mature, healthy, well young adult, and even beyond into older adulthood. This is our objective. This is our goal for all of our patients. But what we do know is that there is, in fact, tremendous variability in patients with single ventricle and Fontan circulation. And this is a true statement that I've come to the conclusion of late, but is, I think, simple but profound. There are no two individuals with single ventricle Fontan circulation that are exactly alike, and no two have the exact same expected outcomes. There are subtleties in their anatomical makeup, their historical aspects, as well as how they are manifesting as a child, an adolescent, or young adult in terms of the variations, the variety of things that can manifest in our patients with a Fontan circulation. And what predicts how somebody is going to be and turn out is incredibly challenging and essentially impossible to do. A metaphor that one can use is that our patients with single ventricle Fontan are on a cliff, and the vast majority of them are stable and on that cliff, but we fear that occasionally they might fall off. But while they're on that cliff, these are the things that they own. These are the things that make up part of who they are. A physiological state of increased pressure in the veins and low cardiac output. Variable degrees of end organ dysfunction, including liver fibrosis, lymphatic system stress, poor growth of the bones, manifested by something we'll discuss a little bit further, low vitamin D and high parathyroid hormone levels, exercise intolerance, neurodevelopmental deficits and learning challenges, as well as anxiety, depression, mental health challenges. The problem is that we cannot accurately predict the trajectory of these patients. Are our kids going to stay on this cliff? Or are they going to move on to the less steep part of the cliff? Or, unfortunately, are some of them going to fall off that cliff? The answer is yes to all of that, but how do we begin to gauge and measure who's going to do that and understand what needs to be done in a proactive manner as opposed to a reactive manner? We can't yet do that today. The beginnings of trying to understand distinctive groups is starting to emerge with some data. And this is unpublished data at the moment, but I'll quickly go through this with you. This is work from the Australian-New Zealand Fontan Registry, where they've looked at over 800 patients over the age of 16 with a Fontan circulation. And they stratify them into two groups, low risk and high risk. The low risk are in blue, the high risk are in red. High risk are patients who have sustained arrhythmia, thromboembolism, lymphatic insufficiency, or other complications. What you see here, and the main point of this curve, is if you reach the age of 16 and you're in a low risk group, in essence, this curve would predict getting out to 40 plus years of age with a 75-80% freedom from Fontan failure and doing well. In other words, for the first time, we have data to support something that we were very hopeful of, which is if you have a healthy adolescent with a Fontan, that the vast majority of those patients are going to continue to be healthy and well as they get into their adult years, even into the age of 40 or plus. Now, we'd love to have more data into senior citizenship. We just don't have those numbers yet. But it does prove the concept that there's definitely going to be a cohort of patients who are actually going to do well. We used to think, my goodness, all of our patients with a Fontan are going to need a heart transplant at some point. Not the case. That is not true. On the contrary, the vast majority of such patients, and a select group, but a large number, are going to continue to do well as they enter into their adult years. So what do most cardiologists do today when we have our 6, 8, 10, 12-year-old with a Fontan? We see our patients perhaps every 6 to 12 months. We get an echo and an EKG. We marvel at how wonderful it is to see these kids, and we gush at how great it is to have a child who's alive, somebody who was born with a lethal birth defect. We give them a hug, and we see them again in 6 months. We tell them the echo looked great. This is what I've been doing for many, many years. For many of my patients, I continue to do this. But it's not enough. It is insufficient in predicting who is or isn't going to do well as things go down the road. Awareness, screening, and surveillance, and a proactive strategy in progressive care is the new model that we are employing. Much of this is well described in the American Heart Association scientific statement that I was honored to chair, which came out a little over a year ago, summer of 2019, where we talked about a number of different things that we want to focus our attention on, in particular surveillance, and made some recommendations for surveillance screening, as you see here. Again, there's a lot of detail here, and I refer you to the paper if you're interested in learning more about it. But the notion that we need to dig beneath the surface and we need to survey our patients for things beyond just what the echo looks like is critically important. We've developed an entire program that we're calling our Fontan Forward program, Forward standing for Fontan Rehabilitation, Wellness, and Resilience Development Program. It gives us the opportunity to harness the skills of subspecialists such as liver specialists, endocrinologists, of course cardiologists, but immunologists as well, and offer comprehensive screening. Of late, we've added elements of exercise physiology, a dedicated psychologist to the group, a dedicated nutritionist, and an educational program for our families. All of this with the hope of enhancing their understanding of the uniqueness of the Fontan circulatory state. Examples of some of that uniqueness relate to the heart-liver interaction. I'm not going to get into too much here, but we do know that the liver is of importance. And another area of key importance is neurocognitive outcome in our patients, and looking at what our adolescents are like and tracking them back to how things may have started even before surgery. What we now know today is we can make the statement that close to 2/3 of young adults with single ventricle Fontan will have some disorder of behavior, psychiatric morbidity, and attention deficit disorder type hyperreactivity. This leads me to a work that we just recently completed, and it's now in press in the Journal of the American Heart Association. And this was a study where Scott Weinrib, who's one of our cardiology fellows at the moment, and I got together. We looked at our data from our Fontan Forward group. We studied 265 subjects, did exercise testing, and looked at the exercise test values in comparison to the detailed forward evaluation. Forward evaluation included a whole series of lab assessments looking at all the different organ systems. And we were looking to see what was associated with top-notch exercise performance. What we found was 1/3 of our patients performed at that greater than 80th percentile. So good to know. 1/3 of patients actually performed quite well with the Fontan circulation. And on different types of analyses, here's what we found. Platelet count, lymphocyte count, vitamin D, and age were associated with exercise. And on a multivariable regression, which is a more sophisticated statistical tool looking at multiple variables, most important findings were that vitamin D sufficiency and absolute lymphocyte count were associated with an increased exercise capacity. Obesity and overweight was negatively associated. And importantly, things that were not associated included the ventricular morphology, the type of Fontan, or the age at which you had your Fontan. So whether you were a single right or single left ventricle did not appear to make the difference. When we start to look at this, we can begin to say that perhaps we can begin to craft a tool. Wouldn't it be great to have a tool that can provide a Fontan circulation wellness score that is valid and reliable in predicting the course and trajectory for our patients? So here we have the Weinreb data using exercise as that measure of wellness and all these other laboratory values that were associated with it. But let me throw out something as a proposal with the idea that this needs a lot of work and it needs a lot of discussion, but the time has come for us to start a discussion. And I propose this Fontan Circulation Wellness Score, 10 different points where we would ask the patient, assess their state of vitamin D sufficiency, whether there is or isn't obesity, their absolute lymphocyte count, which reflects how much lymph they may be losing in the gut, parathyroid hormone, which is a measure of overall bone health and wellness, platelet count. The lower the platelet count, the greater the degree of consumption and perhaps more liver scarring, liver elastography values, estimated kidney GFR values, exercise capacity on exercise testing, as well as some measure of school educational capacity and some composite measure of behavioral psychological capacity. If we put these points together in this 10-element scoring system, we have a composite of how well a particular patient is doing. And then, of course, we would have to take this information and validate it to see to what degree it could correctly predict the development of complications and the quality of life of our patients with a single ventral Fontan circulation. But it's a start, and I think we have some data to begin our work on. There is a way to validate this. The instrument and tool that we'll use, that we hope to use, is the coming just tsunami of data that we expect in the next few years from the development of the Fontan Outcomes Network. We're hoping through the NPC-QIC to collect information in the Fontan Outcomes Network and capture data on a few thousand patients with the Fontan circulation nationwide. And one of the hopes is that we would be able to utilize that data to help us validate this Fontan circulation wellness tool. So thanks for your attention, everyone, and I hope you enjoy all of these presentations.
Okay, another excellent presentation. Thank you so much, Dr. Rychik. And do we have any questions, Andrea?
You have a few, but if anybody has any more, quickly type them into the chat box and or on Facebook, and I will get to them if we have time. I have two questions. One is, are there other centers doing this? And if so, how many?
Yeah, thanks. It's a great question. I will say that what I presented to you is a proposal of an idea, and we have not implemented this in any way, but there is no question that this is not going to be center specific. This has to be patient condition specific. And by that, I mean all patients who have single ventricle Fontan will have to have this particular tool validated in them in order to be able to utilize this properly. This will not be a single center specific instrument in any way. This will be an instrument that we would hope would be able to use, that any practitioner could pull out in their clinic setting and apply and give them a sense of how well somebody is doing, right? I mean, that's the objective here. It is to say, look, to date, we look at the echo. If the echo looks okay, things are all right. And we say, see you again in 6 to 12 months. But we know that things are brewing beneath the surface and that there's lots of different activities that are going on in the body of somebody with a unique type of circulation, such as this one. Let's begin to get a glimpse of what that activity is and to grade that activity with the hope that we can modify it potentially and maintain good scores, steer patients into the right direction to maintain a relatively high wellness score on this Fontan instrument. Will not be center specific, it'll be patient specific.
Great. So that actually leads me right into the second question that we had, and that is, will the patient then need to go to all of the different clinics to get testing done? And if so, who is going to coordinate that care?
Yeah, also great question. Part of the development of a tool like this is to begin to encourage our community, our healthcare community and patient community, the partnership between the two, to appreciate that more detailed surveillance is necessary in order to understand where any individual patient is. We're not going to be able to best guess or best plan for the future unless we open our eyes and open our minds to the notion that we need to do some more testing. And that testing is not terribly onerous, and I think it's occurring already. You know, the culture has changed dramatically just in the last 5 years since I think we've started to, and many others have started to introduce this notion that there's more than just the heart that's impacted when you have a single ventricle. But I think it won't be sort of, going to different labs or different specialists to get the testing, but rather that there will be centers that will develop in the same way that any individual patient went to a specific congenital heart center to have their surgery done early on. They will similarly be able to go to some center that will allow for this comprehensive evaluation. And again, none of this is magic at the moment. Much of it is some blood testing. There is some advanced ultrasound that might be necessary, so more hospital-based. But then again, one can do those different types of assessments at different intervals. It doesn't have to be every 6 to 12 months. In fact, it shouldn't. Probably could be every 2 to 3 years, according to the American Heart Association recommendations. That's what we're suggesting. So I think that what will happen is there'll be an evolution of the development of systems that will allow for these types of assessments to take place, where your local cardiologist will be able to say, okay, you're doing well, but let's get this 3-year comprehensive evaluation and let's collect the data.
Thank you so much, Dr. Rychik. You guys are, as you know, I have a personal love of Children's Hospital of Philadelphia, but you guys are just doing excellent work, and this is a wonderful innovation, and we'd like to see it spread everywhere because this is just really important to Fontan patients. Thank you so much for being here.
Thanks very much.